In this video, we shall be discussing NEET PG Ophthalmology previous year questions of 2020 to 2025, last 5 years question on the topic of conjunctiva. Okay, this is very important topic as so many image based questions come from the single topic of conjunctiva. Okay, so this is very important. Okay, so let's start. First question is a child present in the OPD with following finding. What is the diagnosis? Options for limbal dermoid, pyogenic granuloma, papilloma, and pinguicula. So the answer is limbal dermoid. But as I told you, we'll not only understand the question, but we'll also learn the topic so that we can answer many questions which comes from the same topic. So the topic is limbal nodules. And which are the limbal nodules? These are the limbal nodules. But yes, you are right. They all look so similar. This is very confusing. So to remember which are the limbal nodules, we'll understand it by one mnemonic, that is P cube DOP. Okay, so P cube and DOP DOP. So first is pinguicula, then is pterygium, then is pyogenic granuloma, then is dermoid, also called as limbal dermoid, poisosen, and papilloma. So now we'll understand one by one how to identify them and differentiate them in the exam. So the first piece, pinguicula. They'll show you such image. So pinguicula is a yellowish degenerative nodule that does not cross limbus. As you can see, it is not crossing the limbus. So what will be the MCQ clue? Old age patient presenting with this image, what is your diagnosis? Okay, so we have to remember it. It does not cross limbus. Then the next is pterygium. So it is very easy to diagnose pterygium because it is a wing shaped mass, fleshy mass, and it crosses the limbus. As we can see, it is crossing the limbus. And the MCQ clue will be patient living in tropical climate because pterygium is more common in tropical and windy climate. Okay, but pterygium is very easy to diagnose and identify. Third P is pyogenic granuloma. So it will look like this. It is a vascular mass occurs due to exaggerated immune response following pterygium surgery. So the very important MCQ clue will be the past history of pterygium surgery. Patient will be having past history of pterygium surgery, and this mass bleeds on touch. When you try to touch it, it bleeds on touch. Okay. Third and most important one is dermoid, also called as limbal dermoid. It is a choristoma. Choristoma means normal tissue at abnormal location. So what is the normal tissue? Normal tissue is a skin-like tissue, hair and fat inside it, but they are at limbus, which is abnormal location. So it is also called as choristoma. It is a whitish yellowish lump. Okay. So the MCQ clue will be the age of the patient will be younger. It is a child. Location will be infratemporal location. As we can see, this is nasal and this is temporal and this is infratemporal. How we can know that this is nasal? We can see this plica semilunaris. Okay, so this is nasal location and this is temporal. So this infratemporal location, and sometimes they will also give other systemic anomalies. So what is systemic anomalies can be there? So the most common is golden hour syndrome, oculo-auriculoverbal syndrome. It is associated with limbal dermoid. Why it is called oculo-auriculoverbal syndrome? Because oculo means in eye will see limbal dermoid, in auriculo means ear will see preauricular tag. As we can see here, preauricular tag, limbal dermoid in the temporal infratemporal location, as we can see infratemporally preauricular tag, and in verbal means vertebrae there will be hemivertebrae, and hypoplasia of malar and mandibular region. Okay, so this is highly important topic. Okay, limbal dermoid plus golden hour syndrome. Other is OSSN, ocular surface squamous neoplasia. It is a rare question to be asked in NEET PG, but still we have to remember it because it comes under differential diagnosis of limbal nodules. So we'll see one nodule which is crossing the limbus and also involving the cornea. We can see whitish areas and dilated vessels. So these dilated vessels are feeder vessels. This nodule is OSSN, and the whitish region which we are seeing is a leukoplakia. Leukoplakia means keratinization. Okay, so three important points to remember: feeder vessel, leukoplakia, and corneal involvement. We'll go from conjunctiva to cornea. Feeder vessel, leukoplakia, and corneal involvement. And the last is papilloma. So papilloma has a typical appearance, but we can confuse it with a pyogenic granuloma. But the most important differentiating feature between both of them is pyogenic granuloma will be having past history of pterygium surgery, while papilloma will not have any such history. And it will have a cauliflower like growth. It is a mobile and pedunculated lesion. And one thing we have to remember is it is caused by human papillomavirus 6 and 11. So this is all about limbal nodules. Okay, we'll move on to the next question. Now, the second question is: a 27-year-old IT professional has presented to you with intense watering, redness, and foreign body sensation since 2 months. He gives history of using contact lenses. He applied eye lubricant to help elevate his ailment but didn't provide any relief. What is the most probable diagnosis? So, options were acute trachoma, follicular conjunctivitis, giant papillary conjunctivitis, and vernal keratoconjunctivitis. So, the answer was C, giant papillary conjunctivitis. But we'll see why it is not trachoma, why it is not follicular conjunctivitis, and why it's not vernal keratoconjunctivitis. But we can rule out this follicular conjunctivitis by seeing this image. But what we are seeing here is a giant papillae, not follicle. So obviously this option is ruled out. Now we left with these three options. So we'll see one by one why this is only giant papillary conjunctivitis and not other. Topic is giant papillary conjunctivitis. So you can remember giant papillary conjunctivitis with this just one flashcard. We'll see one by one. So, what is giant papillary conjunctivitis? It is a chronic allergic inflammatory condition. It is caused by mechanical irritation. Okay, so it is first of all chronic. First of all, it is chronic allergic reaction caused by mechanical irritation. So, now we'll see what causes mechanical irritation inside the eye. So most common is contact lenses. Second is ocular prosthesis, exposed sutures, filtering blebs, and scleral buckle. These five causes you must remember by heart, okay? This can be asked anytime. Which of the following cannot cause giant papillary conjunctivitis? Like that, okay? So now as we can see, most of the population uses what? Contact lenses. Because in not in many people we see ocular prosthesis, or not many people undergo surgery where we use sutures. Not many people go undergo anti-glaucoma surgery and RD surgery. So obviously what most of the people uses is contact lenses. So as obvious, most common cause of giant papillary conjunctivitis is contact lenses. Okay, now we understood the causes. What causes giant papillary conjunctivitis? Now we'll see pathophysiology. So it is a type 1 and type 4 hypersensitivity reaction. When mechanical irritation occurs, there is a mast cell degranulation happens, and it releases histamine, eosinophil, and cytokine. Okay, it releases histamine, which causes itching, watering, redness. Okay, So first of all, what has caused irritation, we have to remove it. Okay, so remove offending agent, like stop using contact lenses for a while. Now what we are left with is a mast cell and histamine. So topical antihistaminic and mast cell stabilizer. And as we know, whenever there is an allergy, the most potent agent is steroids. So topical steroids like loteprednol. And in very severe cases, we can also give prednisolone, but in very severe cases. But first, but one thing we have to remember is do not give steroids for long term, as it can cause secondary complications like glaucoma and cataract. Okay, so this flashcard you have to remember for giant papillary conjunctivitis. Now, important one-liners from this is most common cause of GPC is contact lenses. Location of papillae upper tarsal conjunctiva. Size defining giant papillae is greater than 1 mm of papillae. Key difference from BKC is mechanical irritation. Now, now we have seen that what is giant papillary conjunctivitis. Now we left with why it is not BKC and why it's not trachoma. Important difference is giant papillary conjunctivitis and vernal keratoconjunctivitis because both of them have papillae. So first we'll see what is vernal keratoconjunctivitis. Vern is Latin word which means spring or summer. Okay, so as the name suggests, this type of conjunctivitis happens most commonly during spring and summer season. So it is also called as spring catarrh. Okay, now we'll see this giant papillary conjunctivitis can happen at any age, obviously, because anyone can undergo surgery, anyone can use contact lenses, but this vernal keratoconjunctivitis happens mainly in children and adolescents, and that too male predisposition is there, and the main primary cause is allergy or atopy. Now age, at any age, this is children adolescent mechanical irritation, while this is due to allergy. Now Horner Tranta dots we can see in vernal keratoconjunctivitis but not in giant papillary conjunctivitis. Seasonality, of course, VKC. Duration is can be self-limiting. It is usually persistent. Papillae location in upper tarsal conjunctiva, while this is seen in upper tarsal, palpebral conjunctiva plus limbal conjunctiva is a Horner Tranta dots. So what is Horner Tranta dots? It is nothing but the limbal papillae with apical cellular whitish cellular deposits. So why it does not happen in case of giant papillary conjunctivitis? Because this eosinophils response is more in VKC but not that much in case of giant papillary conjunctivitis. Okay, the eosinophil is responsible for white apical cellular deposits, so that is more common in VKC. Okay, so remember this difference also. Now we're left with trachoma, but trachoma we'll see as a different topic so that we can differentiate it from that. Okay, understood. Now move on to the third question. Third question, a patient present with a nodular swelling near the limbus. Okay, it is a nodular swelling which blanches and recurs after treatment. Based on image and clinical presentation, what's the most probable diagnosis? Options were A, episcleritis with rheumatoid arthritis, B, scleritis with rheumatoid arthritis, pinguncula, or D, dry eye. We will eliminate each option one by one. First is dry eye. We know that in dry eye, we don't get this nodular swelling. This congestion can happen. Okay, dull congestion can be there in case of severe dry eye, but not this nodular swelling. So this option is cut. Now is pinguncula. As we have seen in the first question, the topic of limbal nodules, that pinguncula is a yellowish degenerative nodule and it happens more towards the limbus side. This lesion is away from the limbus, and this is not a yellowish degenerative nodule. This is transparent fluid filled nodule. Okay, so the pinguncula option is cut down. Now we are left with episcleritis with rheumatoid arthritis and scleritis with rheumatoid arthritis. First, we have to see this. Either these we have to see, is it a conjunctival congestion or a deep congestion. As we can see here, this pinkish and reddish vessels which are lying deeper at the deeper level. So either it can be episcleritis or scleritis. So we'll see the difference. This is very important difference. Okay, be mild discomfort in case of episcleritis, while scleritis will be painful. Vision will not be sight threatening in case of episcleritis. It can be sight threatening in case of scleritis. Pinkish or mild red in case of episcleritis, while it is a red or blue purplish hue in case of scleritis. Blanching. So it blanches with phenylephrine episcleritis, while scleritis does not blanch with phenylephrine. And management is usually self-resolve and with artificial tears. Scleritis requires systemic steroids. So now we have seen the clue is the blanching. Okay, if it blanches, then we have seen it is a episcleritis. So answer is episcleritis with rheumatoid arthritis. I have created a detailed video on difference between episcleritis and scleritis on my channel. You can watch if you want to learn the concepts and remember it with just one image. I will put the link in the description box below. Fourth question is, a child came with a dark colored expanding lesion on one side of the face since birth. What is the most likely long term complication for him? So the keyword here is dark colored expanding lesion on one side of the face since birth. The complications option are cataract, glaucoma, malignant melanoma, and loss of vision. So the answer is glaucoma. Why? First, we should know what vision. So this is called nevus of Ota. So this condition is called as nevus of Ota, or also called as oculodermal melanocytosis, where skin and conjunctiva of one side has increased melanocyte production. Deep dark colored patches on the skin and conjunctiva. Increased melanocyte will block the trabecular meshwork. Trabecular meshwork is the drainage site for aqueous humor situated in the angle of anterior chamber. So this trabecular meshwork get blocked, so it will cause raised in intraocular pressure, that is called as glaucoma. Now, the late complication of this is also is the malignant melanoma. But here, that is very rare complication. Most likely complication is glaucoma. Okay, so this is the answer. So we'll come to the topic, which is pigmentary lesion of conjunctiva. What all are the pigmentary lesions of conjunctiva that can be asked based on this question? That are conjunctival nevus and malignant melanoma. As we can see, conjunctival nevus is a patch of melanocytes. Okay, it is a very benign condition. This can be seen in some of us also, and we see many of this patient coming to the OPD. But we just have to observe these patients to see if this lesion is increasing in size or and raised lesion. That's all. Okay, so this is benign condition. Next is malignant melanoma. As the name suggests, this is a malignant condition. We can see darkly pigmented raised lesion, okay, with surrounding patches of pigmentation with feeder vessels we can also see. So this is malignant melanoma. Now, nevus of Fota can also transform into this malignant melanoma, but for that they have to give some pain, raised lesion like description in the question, but that is not given. So the most common complication is glaucoma. So that's why the answer of that question will come as glaucoma, and other pigmentary lesion are nevus and malignant melanoma. You told me that the patch was not blackish, it was something like reddish. So if it is the case, can be the answer. That is the Sturge Weber syndrome, where port wine stain of one side of face is there. So Sturge-Weber syndrome, the classic triad we have to remember is Port-Weinstein, that is also called as nevus flammis, leptomeningeal angioma, and the ocular involvement occurs in the form of glaucoma and diffuse choroidal hemangioma. So in either cases, the answer will come as a glaucoma. Okay, remember this Sturge-Weber syndrome also. So now let's move on to the last question. Identify the defect shown in the image. Okay, this is the defect shown in the image. Option is Herbert pit, hornet rantadotes, gelatinous papillae, and pennus. So two options are cut. Hornet rantadotes, as we have seen, this is seen in VKC. Okay, so hornet rantadotes is not seen in. So this is not a hornet rantadotes, and hornet rantadotes is a gelatinous papillae with white cellular apical deposits. So these two options are cut. Now we are left with Herbert pits and pennus. So these two, they both are seen in trachoma. But as we can see, right, so it is a Herbert pits. Now we'll see the topic. That is the topic is trachoma. So in trachoma, what you remember is one classification, one strategy, and six images. Okay, that's all you need for a trachoma. Okay, trachoma occurs due to chlamydia trachomatis infection in the eye. Okay, so one classification, one strategy, and six images. Classification is a FISTO. WHO classification of trachoma is a FISTO classification. FISTO, F is for follicles. So it is active disease which needs a treatment. 5 or more follicles of at least 0.5 millimeter diameter on the upper tarsal plate. Okay, this is important because trachoma is mainly seen in upper tarsal conjunctiva. I is for intense inflammation, pronounced inflammatory thickening which obscures more than half of the normal deep tarsal vessels. So that this is nothing but a intense inflammation. S is for scarring. Scar is old inactive disease. That is tarsal conjunctiva scarring seen as a white fibrous bands. T, other T is a trichiasis which needs correction. Presence of at least one trichiatic eyelash. And O means corneal opacity which occurs from previous trachoma. It causes visual loss. Presence of corneal opacity over the pupil. So you have to remember the Fisto classification. Okay, and the strategy is a safe strategy. S is for surgery for advanced disease like trichiasis. So this Fisto, in this Fisto, F and I, they are active disease, while STO is a chronic and scarring disease. Okay, why? Because S also scarring, T means trichiasis, and O means opacity. Okay, trichiasis means inward bending of the eyelashes. Okay, and S, trichiasis is nothing but inward bending of the eyelashes. S is a surgery for advanced cases, which is the trichiasis. Antibiotics, which is mainly given in case of active trachoma. Facial cleanliness to prevent the trachoma infection in the first place, and environmental improvement to reduce the transmission. Okay, because it mainly transmits via fly. Okay, so environmental improvement. Okay, so these two are mainly preventive strategy, while this two is a mainly treatment part. Okay, so that we have to remember. Now six images, what I told you about is this six images we have to remember. So we'll see one by one each image. Okay, so this is the first image. What it shows: upper tarsal conjunctiva, whitish deposit, as you can see, whitish inflammatory response of conjunctiva. That is nothing but follicles. Okay, intense follicles, and these follicles look like this sago green. Okay, so it is also called as a sago green appearance. sago grain appearance of follicle. What is this? This is the cornea. Okay, this hole is a cornea. And what we are seeing is vessels here and some inflammatory infiltration, which we are seeing here, whitish infiltration. Okay, so this is what, this is a pannus. Pannus is of two type. Okay, progressive and regressive. And regressive, it is defined by the level of infiltration. If the infiltration is ahead of vessels, we are seeing here these vessels are here, but the infiltration is ahead of vessels, so it is called as a progressive pannus. And if the vessels are in front of this infiltration and infiltration is behind, it is called as a regressive pannus. Okay, so only defined by infiltration. To the two images, that is what you are seeing here, this one line is going and some branches are going from here like this. One branch is going like here, this branches are going, they will show like this whitish arrow, they will show. This is the scarring. Okay, so this is the stellate or satellite scarring, which is also seen in trachoma. And here we are seeing one straight thick line. Okay, this thick line we are seeing here, this is called as a Ort's line. It is also line occurred due to scarring of the tarsal conjunctiva. From Ort's line we have to remember one more thing is the Ort's line, Ort's triangle. Triangle is seen in case of acute anti-uveitis, where these KPs are situated in this triangular form. Okay, that is called as Ort's triangle. Now we move on to the next two images. This is the image what we have seen. This is nothing but a Herbert's pit. Okay, and this pit is nothing but the follicles. When this limbal follicles get degenerated, it forms a pit. Okay, that is called as a Herbert's pit. And in the advanced disease, the eyelashes will turn inwards, so that is called as a trichiasis. We are seeing here this eyelashes is touching the cornea. Okay, so this is the trichiasis. And one more thing, lid itself will get inverted, that is called as an entropion. That will happen in case of trachoma. While invert, because this scarring what we have seen here, this scarring, that will stretch the conjunctiva. Okay, tarsal conjunctiva, that's why that will bend inward. In the upcoming video, we shall be discussing previous year question on another important topic, that is lens. Consider subscribing so that you don't miss out on it. Thank you.